A very good evening to all of you. Welcome to Sri Lanka College of Internal Medicine Next Gen Forum, organized by the Young Internist Hub of Sri Lanka College of Internal Medicine. So this Next Gen Forum is focusing on specialist insights from the next generation to our audience who are keen to listen to new insights or in internal medicine and other aspects of medical specialties. Today we have a speaker who is specialized in the topic we are going to discuss. So on behalf of the Sri Lanka College of Internal Medicine, I would like to uh, warmly welcome you. But let me invite our president, Dr. Krishantha Jayasekara, to invite you uh, to the webinar. Over to you, sir.
Uh, Thank you very much, Sahan, and it's actually a pleasure to welcome you for the fourth Next Gen Forum for year 2025. SLSIM is working under the theme of One Nation, One Standard, Achieving Excellence in Healthcare. So the Young Internist Hub was established in March 2025. Actually, this is an extension of what we had the SR Forum for over the years. And the people who were in the SR Forum have all become consultants. So that is why we thought we will move on to a new move. That was a new move to create this Young Internist Hub. So in this hub, we have this what we call the Next Gen Forum, where we listen to the young internists and to the specialized insight into the next generation expertise in various fields in internal medicine. So today we have Dr. Chamara Jayatunga. He's a specialist in rehabilitation medicine, and he will be talking to us on the rehabilitation approach to critically ill patients. Obviously, I think the rehabilitation medicine has greatly evolved over the last few years, and we've listened to many rehab physicians, and this is a new aspect, and I'm really thankful to Sahan for coordinating this and moderating this webinar. So without further ado, while welcoming Chamara, may I invite Sahan to proceed with the webinar. Over to you, Sahan.
Thank you very much, sir. So before we move on to the webinar, the lecture, I would like to highlight few messages which will be very important to our audience. So, after the lecture, we will take the questions for the discussion. So if you have any questions during the lecture, please mention that in the Q&A. So we will have a Q&A session at the end of this lecture. And also, we will share a QR code and a Google link to obtain details to offer you CPD points. As you all know, this webinar offers the participants CPD points. So once you click the Google link or scan the QR code, you will be directed to a Google form. Please provide your details in order to obtain the e-certificate with CPD points. And please note that we will be able to send the CPD certificate within 2 weeks from the time of the webinar. So I hope you will have a great session ahead. So let me introduce our speaker today, Dr. Chamara B. Jayatunga, MBBS, MD, DFSEM, UK. He is a consultant in rehabilitation medicine and currently works in the Rheumatology and Rehabilitation Hospital, Ragama, the largest rehabilitation hospital in Sri Lanka with a rehabilitation bed capacity over 100. He obtained MD in General Medicine in year 2019, and he worked as a specialty doctor in neurorehabilitation from December 2021 to November 2023 at Royal Berkshire NHS Foundation Trust, Reading, UK. He is a diplomat member of the Faculty of Sports and Exercise Medicine United Kingdom since October 2023. He is also a member in multiple panels and service development projects related to rehabilitation medicine in Sri Lanka. And he is one of the very first rehabilitation specialists in Sri Lanka. He is the convener of the expert committee on rehabilitation appointed by the Sri Lanka Medical Association and a council member of the College of Specialists in Rehabilitation and Rheumatology and a council member of the Sri Lanka Association of Geriatric Medicine. Today, Dr. Chamara Jayatunga will talk to you about rehabilitation approach to a critically ill patient, a case-based discussion. So, I cordially invite Dr. Chamara Jayatunga to deliver his lecture. Over to you, Chamara.
Okay. Good evening, everyone, and thank you very much, sir, and the council for inviting me. And thank you, Sahan, for your kind introduction. So the topic that I'm going to talk to you today is the rehabilitation approach to a critically ill patient, and it'll be a case-based discussion. So the objective of this talk is to give an overview of the approach to a critically ill patient from rehab point of view, and also to highlight few concepts of rehab. So let me initially present to you a case that I saw during my overseas training. Mr. A.L., a 54-year-old male, previously fit and well. He cycled 10 to 15 kilometers daily, software engineer, and he lives with partner, and they didn't have kids. And he presented to A&E with progressive lower limb weakness, and the diagnosis was Guillain-Barré syndrome. And then he had ascending and worsening paralysis. Cranial nerves were involved, and he developed respiratory weakness. He was transferred to ICU and required mechanical ventilation. And it was complicated with sepsis and shock. And then actually the patient was referred to us after about 2 weeks into the ICU stay. And when he was medically stable, patient was still on the ventilator when I reviewed him. And neurology team has also been involved, and they have completed the specific treatment. So how to approach this patient, which is a common scenario in day-to-day practice in medicine, how to approach this patient from rehab point of view, and what are the next steps. Before that, a quick recap of what rehabilitation means. So this is the WHO definition, which was proposed in 2021. So rehabilitation is defined as a set of interventions designed to optimize functioning. Functioning is one keyword I would like to highlight. And then to reduce disability in individuals with health conditions. It could be any health condition. That's the second one. And then in interaction with their environment. That's the third one. That's one of the key words, with interactions with their environment. That means, by definition, rehabilitation should be individualized. And then WHO is very keen on rehabilitation service development throughout the world. The reason being, there's a shift in the demographic features of population, and people are living longer. So, but with various problems. So, rehabilitation services are required to people throughout their life course, from newborns, high-risk newborns, to children, to adults, to elderly, and also there's a bit of a gray area of overlapping rehab and palliation towards the end of life. And rehab is an essential health service, and it's crucial for achieving universal health coverage. And WHO estimates that globally, 1 in 3 people are living with a health condition that would benefit from rehabilitation. That's not only the neurorehabilitation, that is including, this means it includes dementia, severe knee OA, back pain, and traumatic brain injury, spinal cord, so autism, psychiatric conditions. So rehabilitation is a very vast area. Right. So we'll come to the core area of the talk, rehabilitation approach to a critically ill patient. And I would like to suggest this 5-step approach, which we generally use in rehab, and which can be used to any situation, not only to critically ill patients. So we're going to identify the disability. We have to do detailed assessments for selected problems, and then goal planning, outcome measures, and treatment. Right. So step one is identifying the problem. So identifying the disability. This is very important. And there are so many ways to do this. And I would like to suggest this WHO model of disability, which was again proposed in 2001, which is called International Classification of Functioning. So like ICD for classification of diseases, WHO has proposed a big list of with codes for every day-to-day activities that we do, like walking, turning, dressing, toileting. Everything has a code and a definition. So in rehab setup, we try to use this. And this is the model. So any health condition can cause impairments in body structure and function. It can cause activity limitation, and it can also cause participation restriction. So if any of these three are affected, that's a disability. And that depends on environmental factors and personal factors. So we'll try to apply this model to our patient with GBS, that is the ICU phase. So what are the affected body structure and function? Patient was quadriparetic, there was dysphagia, he was on NG. There was siluria and secretion burden, he was on the ventilator. There was respiratory insufficiency, bladder and bowel incontinence, mood and psychological impairments, most probably, but couldn't assess in that situation. And probably he might have had pain as well. We have to assume that the patient might be having pain. And then what are the potential complications? The patient can develop reduced joint range of motion. There's a risk of contracture formation, nutritional impairment. He's in a catabolic state, sepsis, ICU, and then cognitive impairments, possibly, but couldn't assess at that time in the initial interview. And of course, the post-intensive care syndrome. So because of this, there will be activity limitations like he was basically managed nursed on bed in the ICU. So all these ADLs were affected. Restriction of participation, of course. So it's I have listed out. Going to work, leisure, social, but not a key thing while in the ICU. But for certain patients, it might be relevant in the acute phase. Right. So according to the model, which is biopsychosocial model of disability, the ICF, these are the disability. But this depends on personal factors like gender, age, and gender is mainly for bladder functions and reproductive health, age and other health condition, his fitness, upbringing, so many individual things, coping styles, social background, education, past and current experiences, and insight, motivation. So these are the personal factors which can kind of affect the disability. And then comes the environmental factors, the barriers, the financial situations, the social stigma. Now, this is a very important slide in the talk. So this is the identifying the problem slide, or the first step. And I think some of you might have heard this. So there's a saying, if we have identified the problem, half of the solution is already evident. And in rehab, we'll be seeing complex patients. So I truly believe in that. Therefore, we try to get this map sorted. It might not be possible in the first interview. We might have to ask from the ICU team. We might have to go through the medical records, give a call to the family members, and try to get this 5 domains listed out, at least the impairments in the beginning, and a bit of social. Because when the patient is on ventilator, participation restriction and activity limitations might not be very hard to determine. But these 3 are very important. Right. So we identified the problems. And as I mentioned, so this is a screenshot from WHO website. So it gives a code for all these. On the left-hand side, you can see the functions that they have categorized. And for example, this is just one section of it. So body function, it goes into mental function, and then it can be global mental function. So orientation, conscious level, everything has a code. This is for research level. Like attention is B140, memory is B144. So, I mean, this is how the categorization goes. But we don't need it for day-to-day practice. Right, step 2. So we identify the main problems. Now we need to do detailed assessments to define the extent of the problem. Again, as I mentioned, detailed history. When the problem is complex, so we have to go back to the basics. So history examination. Sometimes not in especially in critical ill patients, it's difficult to obtain history. They are delirious, they are ventilated, they are on various sedating medicines. Therefore, we have to rely on past records and your colleagues in the critical ill or the HD or the ICU and from family. And then very important to define the baseline functional level. So in this gentleman, he was fit and well, cycles many kilometers. So he drives, so very active person. And then if you need, there are assessment tools to define the extent of the problem. For example, if you are worried about sialorrhea, there's a assessment tool. If you're worried about, or if you're concerned about the muscle weakness, you can check muscle power. If you're concerned about pain, there are pain scores. So you can go into objective assessments. But sometimes it's limited when the patient is critically ill, and especially in the ICU. So you leave it for a subsequent examination. So as I mentioned, patients generally they need multiple visits to the ICU and serial examination. And sometimes they are very fragile patients. So we might need combined session with ICU doctors or the medical team. And if you have your physio, so rehab team, physio team, as well as the ICU team, we can do combined because they need everybody's inputs to, get the required care and safety ensured. And as I mentioned, so muscle weakness, we can do the manual muscle power. If the patient is cooperative and aware, the patient is having the awareness. Joint range of motion, that can be checked. Active joints, if the patient can voluntarily move it, but otherwise passive joint range of motion can be checked. If the patient is having complex needs, obese patients, they need specialist or different or specific positioning due to ventilatory requirements. I would suggest to get the help of to do this assessment combined with the ICU doctor or ICU nurse and the physio. Sialorrhea, pain, nutritional scoring can be done, and then cognitive impairments, difficult to do while the patient is in ICU, but can at least do a basic screening of cognition, whether the patient is alert, awake, oriented. Right. So this is the drooling rating scale, which is very easy to do. Just a suggestion. Right. So we identified the problems. We did detailed assessment for selected problems. And then we had to do goal planning. One of the essential components in rehab. And goal is the intended outcome of a specific set of interventions. And first step is to establish what are the goals important to the patient. But when the patient is in ventilated situation, perhaps we might have to go for best interest decisions. So usually done by agreement of two consultants, so maybe the physician and the rehab physician, or the ICU consultant and the rehab physician. Of course, we have to get the inputs of the family as well, or the next of kin. And this is the generic acronym of a goal. So it has to be specific, measurable, achievable, realistic and relevant, and timed. So this can be used for any goal, your personal goal, academic goal. So in rehab also, we follow the same. And the expected time to achieve the goal is very important, something we have to perhaps include in our practice. We sometimes do not put a lot of focus on the time, because we don't consider the cost or the burden of a patient staying unnecessarily, perhaps, or utilizing the health services beyond the required time. So time is very important in overseas practice. They put they plan the discharge very kind of early in the course of the illness. So just a suggestion. So put a time, like even for your medical management. So like antibiotic courses, like in rehab also, we have to put a time. So, okay, we are going to achieve this goal at the end of 3 weeks, 4 weeks, maybe 6 weeks. But that's very important to send it across to the patient so that patient and the therapy teams and the rehab team can work towards that goal. And then it depends on patient factors, experience of the rehab team, and of course the natural history and the available research data of the health condition. Right. So what are the main rehab goals for this patient while in the ICU, while on the ventilator? So to preserve passive joint range of motion in limbs for 3 to 4 weeks. That was an arbitrary guess after having a chat with the ICU consultant. They thought patient will need another 3 to 4 weeks to wean. So that's where the T came from. For certain goals, we can't put a time. For example, to preserve muscle mass as much as possible. And this is a very important goal. As a rehab team, we can do a bit of in-reach services to help the ICU team to wean the patient from ventilation. So we can, if the patient can cooperate, we can do certain, breathing. But if the patient is on ventilation, then perhaps and sedated, and then we can do certain maneuvers to help to reduce the secretion burden. For example, salivary gland botulinum toxin injection. And then patient to be able to sit in a tilting space wheelchair. That's a bit of a advanced wheelchair. I'll show you a photo, which is the required one for these sort of critically ill patients with a lot of support for 30 to 60 minutes by, again, 3 to 4 weeks. That depends on the patient to patient and depending on the condition. So these are some example of SMART goals. So that's specific and they are measurable. So for example, here, 30 to 60 minutes, achievable, realistic, and timed. To prevent pressure ulcers, very important goal, very costly thing. Pressure ulcers, it takes time to heal. And if the patient is referred for rehabilitation with the pressure ulcer, that can interfere with the rehab, like positioning and exercises as well. So we need to prevent them as much as we can. And this is also a very important goal, the last one in a rehab initial interview, to ensure that patient's family and next of kin are aware about the next steps in patient's rehab journey, because it's still the pathways, rehab pathways are not clearly established throughout the country. So sometimes they might not know what will happen once the patient, improves and can be discharged from the ICU. So maybe the rehab team can perhaps take a phone call, or if the ICU pass the message to the family that there are certain steps available, that will be a big relief to the family. So the other rehab goals in ICU, screening for cognitive impairments, if the patient can participate. Pain relief, very important, because of the positioning, because of certain the primary condition. Sometimes neurologically, the pain is very significant burden. And one problem of pain is if it becomes chronic, then it becomes difficult to treat, and they lose confidence in exercises. So pain relief is very important. And controlling problematic spasticity, especially in upper motor condition, which is not relevant to this gentleman with GBS. For example, if the patient is in ICU with a brain or a spinal cord injury, then yes, spasticity can be a problem even while in the ICU. For example, if the patient has severe adductor spasticity, the nurses might find it difficult to passively abduct the legs so that the hygiene can be maintained. So the patient can develop moisture-associated dermatitis and fungal infections in the perineum, right? And then it can cause severe itching, and the patient is unable to do that. So a lot of behavioral problems. One of the common reasons in delirious patients, and patients pulling the catheters, pulling the NGs out. So fungal infections in the perineum is a common cause for that. So and one reason for that is the spasticity, and hygiene and cleaning cannot be done properly. So we can do Botox injections while the patient in ICU during our initial rehab release. And then controlling secretion burden, again, Botox to the salivary glands can be done. We can ask the ICU team, is it secretion a really burden? Then we can think of these things. And in certain or in ideal situations, sometimes the patient can be mobilized while in ICU, let's say to a chair. Sometimes, again, the spasticity can kind of be problematic. You can't get the patient to a seated position. And sometimes the patient can be even made into a standing or like verticalization, one of the very key rehab steps for any patient with low awareness. I mean, we have to get the patient to the vertical position with support, of course. And when the patient is having knee flexion contractures or ankle plantar flexion contractures, we can't get that positioning. So again, we can do these Botox injections while the patient is in ICU. And then assessment for psychological and mood, depending on the patient's condition. So this is the goal, just to introduce you the goal attainment scale, very simple thing that we use in rehab correspondence and communication. So we set a goal that, for example, let's say this is the goal to preserve passive joint range of motion in both arms and legs, 3 to 4 weeks, and to prevent contracture. If we achieve that by that time, then we say the goal attainment scale is 0. If the goal is, let's say, achieved before that, then we call +1 or +2. If the patient achieves a worse than expected outcome, then it's -1 and -2. So if the goal is not met, then the rehab team and the rehab consultants, generally the leaders of the team, will need to see why the goal is not achieved. So that's a big core area of rehab. So there are so many reasons why a goal is not met. Either the patient's primary condition has worsened, new medical problems, the patient is having mental health problems, pain, or unrealistic goal set, which is not in keeping with the primary diagnosis. So we have to check the diagnosis is correct. The primary team has done the reviews. So many causes of why a goal is not met. So we can't just put -1, but always -1 and -2 needs to be evaluated in detail. Right, step 4. So we set goals. Now we need to select certain outcome measures. I mean, as in medical wards, medical clinics, A&Es, rehab clinics are also like very busy. We see so many patients, so we don't have time to go into a lot of detail. But at least we can select one outcome measure depending on the patient's main problem. For example, for an ICU patient in the ICU, maybe I think goal would be to get him out of the ICU as the first thing. But later on, in our rehab, we can select mobility goals, balance, independence goals, pain goals. Right? So we can select. And yeah, as I mentioned, maybe limited while the patient in ICU. If you need a list of these are freely available online. And we have disease-specific outcome measures. Like, for example, brain injury, spinal cord, you can go like that. Or you can go with, like, what's important for the patient for day-to-day practice. And this is a freely available database online. So many outcome measures are. Right. Last step. So we identify the problem, the ICF model, and then detailed assessment for selected problems, set the goals, selected the outcome measure. Now we need to do the therapy. So for that, or do the treatment. The problems were many, so we need a team. So we need a consultant to lead the team. Depending on the availability, it could be a rehab physician or a general physician, rheumatologist, geriatrician, neurologist, surgeon, ICU consultant. So it depends on the patient's need and availability. But a leader is essential to create the team dynamic so that everybody works towards the same goal, and there's somebody to be accountable. And if the goal is not met, somebody to lead the process of finding why the goal is not met. And for medical legal things, so there should be somebody in charge or somebody to lead it. And then we need doctors, nurses, physios, occupational therapists, speech and language therapists, a mental health team, very important, depending on the availability. Prosthetists and orthotists. So prosthetists help with artificial limbs, for example, in amputations. And orthotists, generally, the same clinician is looking after both sides in Sri Lanka. So orthosis means splints. It's a device worn externally to augment a body part. So basically splints. And then social service officer, very important. And the nutrition team, consultant or the nutritionist who is available. And then, of course, patient and the family in the middle. So this is the rehab team. And they all have their own expertise and primary tasks, as well as overlapping, or primary duties, as well as overlapping duties. For example, in my opinion, pain management, or asking, are you in pain, and how is the pain well controlled? Looking into mental health aspects, and helping them to adjust to the disability. I think these things are overlapping. Everybody should be proactively engaged in looking at those aspects. Just to quickly show you how we can achieve certain goals. For example, we set a goal to preserve passive joint range of motion. So how can we do it? So that goal has certain interventions. For example, correct positioning, turning every 2 hours. But again, we have to be practical here. And patient is in ICU and on ventilator. So that positioning needs to be, need to focus on the ventilator related positioning as well. So it's a teamwork again. And resting splints that can be offered even in Sri Lanka. And mind you, these have to be removed every 2 hours. And if you are prescribing this, we have to ask the ICU nurses to inspect the skin. Otherwise, they can get pressure ulcers even to the splint because the patient is not moving. The patient is paralyzed and ventilated, for example. And this is the hand is in the resting position. And then the same thing can be done for resting ankle splints as well. Again, very important to remove them every 2 hours and have a look at the skin. And we are looking at non-blanching erythema as the earliest sign of pressure injury. We don't have this one available in Sri Lanka, but we have something similar, and it generally serves the purpose. So what's the importance of putting resting ankle splints, for example? I mean, these are not needed for the patients who will only have a short stay in ICU, but sometimes patients are in the ICU for weeks. So otherwise, the patient will develop a plantar flexion contracture. And let's say patient improves with treatment and medical management, and then patient is taken to rehab, and we want to get him to standing. But if there's a ankle plantar flexion contracture, standing can be really difficult, and it will take extra time and effort and therapy to get the ankles, plantar flexion deformity improved so that standing and walking can be achieved. So we need to prevent additional disability. So very important to put these splints safely with checking every 2 hours. The ICU stays prolonged. And then, of course, these are happening even, in almost all ICUs, I think, daily passive range of motion exercises. That is to keep the joints healthy, because patient, for example, GBS patient presented with a neurological injury, and we need to keep the joints as healthy as possible. To preserve muscle mass, well, this is purely from rehab point of view, but there are other reasons which kind of override this need. For example, optimizing certain medications. For example, as rehab physicians, steroids might or is not the most rehab friendly. It can cause proximal muscle weakness, central obesity, and bone problems, and so many mood problems. So not very rehab friendly, but very good medicine, of course, to treat the primary thing. So perhaps if the patient can be quickly kind of switch to a steroid sparing thing, better to just ask the primary consultant, maybe the physician, is it possible to consider these options just as an MDT, because loss of muscle mass is a really problematic thing, because even though patient neurologically improves or conscious level becomes improve a lot, but if you have lost let's say your lower limb muscle mass and in the trunk, the patient's balance and standing will be really a challenging thing, and we can optimize the nutrition. Of course, these are like suggestions we have to tailor-made to the patient's requirement. So I discussed this, helping the ICU team to wean the patient from ventilation so we can optimize pharmacological treatment. Generally, these are already happened by the time the rehab referral is done. So we can suggest hyoscine patches, glycopyrronium. And then this is the only thing we can do in extra if it's a real problem. A salivary gland Botox. We can use the ultrasound and do it at the bedside. This is a bit of an important goal. Let's say we set the goal to patient to be able to sit in a tilting space wheelchair for 30 to 60 minutes by, let's say, 3 to 4 weeks. That's the goal. And this is a tilting space wheelchair. So this had head support, and you can Google it and see. The benefit is that this can be, rather than recliner one like a car seat, this tilting space, the entire seat and the backrest kind of tilts backwards so that the patient can maintain the pelvis at 90 degrees. So to achieve this, we need to achieve multiple small goals. It's not it sounds a bit easy, but actually it's a bit difficult. First thing, the patient has to be medically stable. So we have to ask the medical team or the ICU team, can this be done? Sometimes they say, no, patient is not stable, then we can't do this. And then pain has to be controlled. Postural balance has to be optimized. So patient should have a good trunk balance. And then postural hypotension has to be controlled. This applies even when you're mobilizing a patient to the chair, even in your acute medical ward. And we need safe transferring techniques, equipment and staff. And then we need a good wheelchair with cushion and support. So certain ICUs have hoists to facilitate this. We don't have it yet. Right, so goal to prevent pressure ulcers. So again, proper positioning, changing position every 2 hours and inspecting pressure areas. These are freely available online. You're seeing, you can show these photos to the nurses or to the carer in Sri Lankan setup. And then there are special mattresses, which pressure kind of redistributing automatically. And then correct handling and transferring techniques are also important. Otherwise, patient will get friction injuries and shearing. Educating next of kin, discuss that. Right, so patient is in ICU. We have done all these. So what are the pathways for long-term rehab? Generally, in practical perspective, generally when the referral comes, they do it. The ICU team or the physician generally want to discuss these long-term rehab options. So that's one purpose of the referral, and we see them while in ICU. So these option selection depends on the level of disability that we identified, and then the prognosis of the primary condition, and then fitness from medical and surgical point of view, patient preference, if the patient has sometimes mentioned before the patient lost the capacity, or otherwise best interest. Two consultants agreeing with next of kin's agreement. And then, of course, availability of resources. So these are the factors which determine this. And what are the options? So one is intensive rehabilitation. So intensive rehabilitation means generally more than 3 hours of therapy time, total, divided into sessions. So generally done in an inward setup. And then slow stream rehab, again, inward one, but the total therapy time is about 1.5 hours, like maybe 3 sessions of 30 minutes each. Right? So, for example, maybe the most suitable one for a already elderly person who used to. This is just imaginary, how hypothetical situation. For example, elderly person, mild cognitive impairment to begin with or baseline, mainly spend time indoors, walks with either handholds or maybe with a walking frame, right? For severe knee OA. So that sort of a patient might not, or bit of cardiac problems, so might not be suitable candidate for intensive rehab. With more therapy time, they can get maybe not the best outcome. So we can consider slow stream, but unfortunately, we don't have an established pathway yet in Sri Lankan government system. Intensive rehab we can do at the designated rehab hospitals like Ragama, Digana, and in Galle, the Maliban Hospital, and certain units like Ampara in Polonnaruwa. There are a couple of centers in northern province. And then sometimes rehabilitation as an outpatient if the patient improves from the critical illness, and then that's available in Sri Lanka. But home-based rehab is sometimes, despite all your efforts and intervention, sometimes some people remain in a very impaired state or disabled state. So we might have to think of a nursing home. Of course, generally it happens after a period of intensive rehab as well. But let's say the finally patient goes into a nursing home situation. We do not have a government pathway yet. We are in the process of developing one with Sri Lankan resources and our own kind of model, because this is very important. Our population is big, 22 million, and we have a big number of such patients who would need nursing home level care. And at the moment, it's purely given to the families. So there's a discussion going on how we can kind of come up with a model. So early stages still, but hopefully we will get there with the inputs of all the specialists, like all the professional colleges. But the model here is the patient remains in the nursing home or at whatever the health institution, and the rehab team visits the patient because it's really costly and cumbersome, and sometimes can make the patient it can lead to a lot of adverse outcome if you ask the patient to visit the hospital. So the other way around is the best option. We do not have it in the government yet. Right. So coming back to the patient, so what happened to him was patient started improving neurologically after a few weeks. I think I reviewed him about 2 or 3 times while in the ICU. We didn't have to do much. Tracheostomy was removed. He was able to be weaned off. He did not require any salivary gland injections. He didn't develop spasticity because it's a lower motor condition by definition. And then he was stepped down to respiratory ward. And then for a bit of observation before we took to the rehab ward. And then, of course, the next phase would be inpatient specialist rehab. So again, now the patient came to the rehab ward. Again, the same kind of, assessment, identifying the problems, detailed assessment, goal planning, outcome measures, and treatment. So this cycle is what we use in any situation. So I'm not going into the detail, but I'll just mention what are the affected body structure and function now while in the rehab ward. Is after about few weeks from the hospital admission. So predominantly he had distal arm weakness, right? Fingers were weak, and there was severe muscle wasting in his hands. And there were proximal lower limb weakness. He has severe neuropathic pain. I remember he was in big, very huge doses of pregabalin. And small muscle weakness, in both hands, leading to claw hand deformity. Bilateral, he had reduced active shoulder joint. So shoulder joint, even though that was a goal, he had kind of, residual problems. His active range was very limited. And he had dysphagia. I think he was an NG while he came to the NGOPEC. He had dysphagia. And then deconditioning and fatigue, very important. They even get fatigue with even transferring to the chair, they feel fatigue. And then bladder and bowel incontinence. He was very anxious and lack of confidence. So those were the affected body structure and function. And transferring, dressing, using cutleries, toileting, standing, walking, using the mobile phone. He was a software engineer. So signing, driving, they were all affected. So these are the disabilities. And then, going to work, leisure, cycling. He was an avid cyclist. And social integration were problems. Again, the same personal factors and environment. Again, detailed history. Now we can do thorough examinations. Right now, the patient is out of the ICU, so we need to check his vision, hearing, head-to-toe examination, joint range of motion. Very important to document these things in rehab setup, especially in medical legal situations, because when this goes to a court of law, sometimes these things can be questioned. So very important to document patients' baseline levels, tone, and then, of course, and for assessing the rehab outcomes as well. Tone, balance, mobility, transferring. So again, might need combined assessments. And then we need to check the overall functional status. There are so many scores like Barthel Index, FIM, and then home assessments, kitchen, toilet, entrance, barriers. Now we have to plan the discharge from this point onwards. And then mental health, cognition, nutrition, cited the same things as I mentioned. Right. And then again, goal planning, again, outcome measures, and then therapy. So same cycle goes. Now the goals are different. So what are the special rehabilitation concerns after a critical illness? So cognitive impairment, it's very common. We can do MOCA, the Montreal Cognitive Assessment, as a screening test. And if you detect problems, we can do detail-wise like R bands, and there are the like more detailed ones, but generally done by neuropsychologists. And in a clinical setup as doctors, we don't do, but we can at least do the screening. Deconditioning is very common. Fatigue is common. And neuromuscular weakness related to critical illness. So it could be myopathy, polyneuropathy, generally a combination. Very rarely rhabdomyolysis and cachectic myopathy as well. So very important to detect. One reason why actually the patient is generally referred for rehab after critical illness is critical illness myoneuropathy. And then mental health concerns. Sometimes patient can have muscle weakness due to the central causes as well. For example, let's say a patient with a brain injury, let's say traumatic brain injury, requiring ICU. Now patient improves, and then probably it's a combination of like upper motor weakness as well as lower motor weakness. So in that instance, we might need to come to the, like, you examine and come to a overall, what's the predominant one? Is it the lower motor type or the upper motor? Important to plan your rehab interventions as well. And we might get the inputs of the physician there. That's the most likely thing. And post-intensive care syndrome is very common. Right. So what are the goals for our patient while in the intensive rehab phase or while in the rehab ward? So now the goals were trans independently with the use of an aid. Remember, he lived with his partner, and so they are like used to live alone. So they are very keen on their independence. So even with an aid, these are all patient-centered goals. So patient is patient was an active member in the goal planning meeting. So trans independently with the use of an aid by 6 weeks. These goals were kind of agreed by the patient. To be able to walk indoors, flat surfaces with a suitable walking aids. Till the goal is at least he might need a frame, but without supervision. Again, patient is independent there in 6 weeks. So the 6 weeks is the general target for the stay in the hospital. And then we will be doing a goal review in 6 weeks and see whether we need to extend it. Generally in England, it's also a publicly funded health system. So generally they kind of cap the rehab stay for up to 12 weeks, like 3 months, intensive rehab. After that, they go for either community or like private extra inputs. And then to be able to use a self-propelled manual wheelchair for long distance mobility by 6 to 8 weeks. So we have to kind of, tell the patient, look, given your natural history, you're in ICU, there was severe muscle weakness and wasting. So perhaps you might need a wheelchair for long distance mobility, which is self-propelled. So you can do it yourself. But meanwhile, we will be doing exercises and therapy to improve your leg strength, so that perhaps you might not be able to depend on the wheelchair. But this is the goal for the initial phase. And then, of course, to achieve independence in all basic ADLs by 6 to 8 weeks. That means dressing, toileting, feeding, right, having a shower. To achieve swallowing skills for normal diet and fluid by 4 weeks. I think he came with a peg. And then ensure that patient is aware about the condition and help with his anxiety and engage in a leisure activities. That's very important. They give a lot of importance for these goals to the leisure activities, even while in the ward. Again, we need the full team. So I've just listed out what the team members. Can you remember? I mentioned that the MDT will have overlapping duties as well as specific duties. For example, physios will be focusing on transferring, strengthening, balance, gait, and pain relief. Occupational therapists. Occupational here means being occupied. Like, it's not the vocational rehab. Vocational rehab or the job-related rehab is part of occupational therapy. But here, occupational means being occupied, like ADL training, hand, leisure, fatigue, kitchen assessment, cognitive rehab. So they are primary duties. Speech and language therapists for swallowing and communication, and the mental health, prosthetist, social, and nutritionist, and patient and the family, of course. Just to bring your attention to this slide. So since we have a lot of trainees, I think, joined here. So in Sri Lanka, these people with disabilities are looked after by two main government bodies. That is Ministry of Health, where we belong, and then the Ministry of Social Services. So the Ministry of Social Services, they have their own budget. And that is how, at the moment, like, we give free, like, medicines from the hospital. For these patients with disabilities, the required services are mainly by the Department of Social Services. So as future consultants, I would like you to suggest, you can just tell this to the patient. The paperwork needs a bit of time and active kind of, follow-up from the patient party, but that is how, with, things with related to paperwork. So you can kind of delegate this task to the patient party. But to tell them, like, for example, this is a RRH document where we have listed out all the available things. So it says we have disability allowance like 7,500 per month now. I know, not a fancy amount, but the patient can perhaps save it for 6 months, and you can buy a standard wheelchair for about 45,000. And there are home like renovation, that sort of allowance. And then some people have squatting type toilets. So if the patient can't do squatting with, let's say, proximal weakness or balance problem, they will need a commode toilet or a commode chair. So there's a provision for that. Any doctor can sign, maybe a trainee or a junior doctor can sign, and the consultant can countersign. You can tell the patient, go to the either Gram Sevak or to the, usually you have to go to the divisional secretariat. They have a social services officer, and that person can give you the required forms, and you can just give the recommendation and put your signature. And you don't need a rehab team to do this. You can get your hospital physios to get that their inputs as well, whether the patient is needing this. And then it says access. The fifth one here is to improve the access to houses. For example, some people have steps, the houses are in level. So if the patient needs, now, for example, our guy with the GBS, for him to enter the house with a wheelchair, so perhaps we might have to change the access, put a ramp. So those things, they are a bit of dedicated funding. And then vocational rehab, like self-employment, transport allowance. So basically there are certain things. So I would suggest you to link the patient with the social services. Right. So what happened to the patient after that intensive rehab? He was able to transit independently. This is after 6 to 8 weeks. He was able to walk indoors with an elbow crutch, but without supervision. He was able to use a self-propelling manual wheelchair for long distance. So patient was taken out to the, road in front of the hospital, and these were checked by the physios. And he was okay. Peg was removed, normal diet and fluids, bladder and bowel continent. His neuropathic pain was largely controlled, but he still needed low doses of pregabalin. And can you remember that he had bilateral shoulder problems or reducing active range of motion, but two primary pathologies. One side, it was adhesive capsulitis. So we gave a bit of, so the active range was reduced throughout. So we gave a bit of steroids, and that improved. But the other side, it was muscle wasting. So we didn't inject. That is, he has lost all the muscles, and then it was weak. And then bilateral claw hand deformity persisted, but he was able to operate a mobile phone and his laptop. So this was his. So he had residual problems. So now we need to come up with a follow-up plan with outpatient therapy and a home exercise plan and review maybe in 4 months. Yeah. Next steps: discharge destination was agreed as home with certain modifications, and then arranged therapy follow-up and medical follow-up. That brings to the end of the talk. So the take-home messages is one is maintaining good coordination and communication among the ICU and rehab teams will help functional recovery of critical ill patients. And also, like, same thing, like early rehab friendly ICU culture, because myself, for example, we work very closely with so many ICUs, trauma ICUs, medical ICUs, surgical ICUs, and generally they work very hard. The ICU teams, the medical teams or the surgical teams to, save patients' lives, and they are very happy to see them functionally improve as well. So, so this early rehab-friendly culture is happening, and that will really benefit the patient. And WHO's ICF model is useful to identify the problems and the planned rehab interventions that we discussed. And I would suggest you to set patient-centered SMART goals, not what the next of kin or their family wants you to, but of course get their involvement. They are part of the plan, but it has to be what the patient wants. And lastly, it's a MDT service. You need multiple professionals to deliver this. And I would like to acknowledge all the consultants and other clinicians and admin staff involved in initiating and maintaining current rehab services. And of course, to the ICU and neuro rehab team at Reading, and to all my teachers and my patients. And these are my other references. And thank you very much for your attention, and happy to take any questions if we have.
Thank you very much, Chamara. Thank you for that insightful lecture. I think the audience would agree with me. You have very smoothly and you have taken us through this journey of the rehabilitation of a patient after critical illness.
Sure.
So we have, I think this has brought new insights to our audience as well. So we have a couple of questions appearing in the Q&A, and I would also like to invite our audience, the participants, to post your questions in the Q&A section, so I can forward the questions to our speaker. And in the meantime, I would like to share the QR code for the CPD certificate. Dr. Jayatunga, if you can stop sharing the screen,
Sure.
I would be happy to share the QR code for the CPD certificate details. I think everyone can see this. And I have also shared the Google link for the Google form. Please provide your details if you want to receive the CPD certificate with the e-certificate with CPD points. So let me forward the questions. I think we can see several questions. So first question is, what is the time period that we need to consider to start rehab in a patient with transverse myelitis caused by an infection?
All right. I think the answer would be, I mean, it's an individualized decision. Generally, I would say, or when I would see that, I would think that the patient will gain the maximum from rehab visit would be when the patient is stable and when you are, I mean, when the patient can be mobilized, perhaps. Like, for example, if you are, if the patient is, unwell and you are escalating the medical management or escalating the what you call respiratory support, or whether when the patient is, let's say, needing other organ support, like in a bit of a escalating phase, perhaps you can delay it. But it's not disease specific; it's the patient's general condition. And once that condition is over and patient is kind of stable, then perhaps it's time, because the rehab beds are also kind of limited. I used to tell, now it's like as of now in Sri Lanka, it's like our railway system. Like, we kind of juggle the patients through our rehab beds. Like, we get from one patient from let's say from NHSL, and then keep him, and then when he's bed kind of okay, we might send him to another ward and get somebody for that bed. So we kind of beds are limited. So and we have a bit of a waiting time, I think, in all the centers now. Not very bad, but not a long waiting time. But at least it will take about like 1 week to get a rehab bed, which is not a bad situation at all. But I would say when the patient is stable, and when the ICU team or the medical team thinks that patient can be considered for next steps, is the time to, I think, to do the referral. But you can start the rehab while the patient even ICU because ICU, the therapies will be visiting the patient, and that can be started as long as the patient is fit for a bit of mobilization. I hope I answered. Just to recap, so rehab referral can be made when the patient's active management is kind of stabilized to plan the next things, but mobilization can be started as soon as the treating consultant is happy with it, with the physios visiting the ICU. You don't need a rehab like a consultant to review to start the things. It's already happening in setup, so it can be continued as it is.
Thank you.
And also, if you think spasticity is there, you can make an early referral and prolong, these vegetative states and low awareness states. So there are 3 low awareness states: either coma, vegetative state, or minimally conscious state. So these patients need a different rehab pathway. So if you think your patient is having such condition, you can make perhaps an early referral, because that patient probably will have the trachea. So we have to take with the trachea. So we need to do a bit of early planning. but otherwise it might not be beneficial to see them very early in the course of illness.
Thank you. The next question is about bed sores. Are already existing bed sores contraindicated to start rehab? Because sometimes patients are not accepted because of bed sores. If they can, what are our concerns?
Okay. Thanks for the question. Yeah. I know some of you might think the rehab hospitals are not accepting because of bed sores. The rationale is very simple. Because, you know, the 4 ethical principles. So we are very kind of, since we see complex patients, so we have to always go by these 4 ethical principles. So autonomy, justice, beneficence, and non-maleficence. So the rationale being there, let's say the patient has a big pressure ulcer. The preferred word is pressure ulcer, or a decubitus ulcer. Pressure ulcer, let's say in the gluteal region, and the patient is in ICU, more like, and the first step is, like, for example, that man, to get him to a seated position. Now, when there's a big pressure ulcer in the gluteal region, we can't get the patient to or we shouldn't get the patient to the seated position, because the treatment for pressure ulcer is not the dressing, not the surgical, they are part, but the key thing is pressure relief, right? So pressure ulcers, the primary treatment is pressure relief, offloading. So you can't offload when there's a huge ulcer in the gluteal region. You can't get the patient to the sitting position, which is the next rehab step. So then when it comes to ethical practice, then the beds are kind of, in high demand. And for example, Ragam is covering so many hospitals, so many units in one hospital. So is it ethical, or is it, I don't know. So that's how why we don't take. Is it okay, or is it ethical to get somebody and do just turning to sides, like until the gluteal ulcer heals? So is it all right for us to kind of keep the patient sideways and deny somebody else's neuroplastic window for active rehab? So that's the dilemma we have. We don't have a agreed pathway, I know, but given the current rehab needs, we believe that, and a lot of units in the health system can look after patients with bed sores or pressure ulcers, turning every 2. I don't think we can kind of allocate rehab beds without any active rehab interventions, just turning every 2 hours till the wound heals, and give the nutrition and whatever the surgical care, while other people are waiting at homes without any rehab intervention while in the neuro-rehabable period. For example, if it's a brain injury, the first 3 to 6 months are the critical for functional recovery. So that's the dilemma and the argument behind that practice, not to like kind of decline their treatment. So even we are and again, it comes to your nursing need as well. Sri Lankan hospitals are not given staff as of now based on the rehab needs. We get the same as in a for example in a medical ward, but our patients need are on peg. They need 2 to 3 people to transfer. So we don't have that nursing inputs to cater many patients with bed sores. So that's why we don't take. But we do take for example, if the pressure ulcer is in the sacrum, and the next goal is sitting, and patient can maintain it without putting pressure, still we accept. All our wards will have patients with pressure ulcer as of now. But if we don't take only if it is preventing us from doing the next rehab thing. So what we do is, or what I would like to suggest is, we might have to send him to a local hospital or to a surgical unit to manage the pressure ulcer, and then keep it, we keep them under follow-up. And as soon as the wound improves to a degree that we can do the next required thing for rehab, then yes, we do take. Meanwhile, it's not contraindicated. You can do loads of things to improve the fitness, the arm, the deconditioning, upper limb strengthening, balance, and those things you can do, right? Pain relief. So many things you can do while the patient is having it, clearly explain it to the patient. And we might have to postpone admitting to a rehab ward, but certain things can, of course, be done without putting pressure on the pressures. Otherwise, it will not heal. Hope it
Thank you.
answers. Yeah.
Yes, thank you. The next question, what should be the ideal time the rehab physician involved during the ICU stay of a patient needing long-term rehab?
Yeah, I think I answered was a similar question to the first one. Yeah, so there's no ideal time. I believe it's the discretion of the ICU consultant or the physician in charge. Generally, I would think the best time would be when the patient is medically stable and organ support are kind of stabilized, or organ support is kind of you are reducing gradually. Like otherwise, I think it's a bit too early. And of course, if you think like silaria management or bit of Botox is needed while in the ICU, is a time for referral. And otherwise, maybe since we have a bit of a waiting time, sometimes you might have to refer a bit early. So there's no hard and fast rule. So I think when the patient is stable would be a okay answer to generalize it a bit more.
Right. Thank you, Chamara. So another question on if a patient has developed DVT, is it a contraindication for physiotherapy?
I mean, generally not, because if the patient has developed DVT, we will be treating it. And so with treatment, we can generally, continue. Should not be an absolute contraindication. Yeah, with therapeutic treatment, and we have even filters. We can go up to that level, but generally, therapeutic treatment should not be not be. It's not an absolute contraindication, but treatment has to be started initially quickly.
Okay. So there's another question. How can a general practitioner refer patients to your hospital?
Yeah, I think still, since we do not have established pathways, I think, and people of disability, they can't, they can't, because it's very costly for them to find suitable transportation. Our public transport is nowhere near disabled friendly. So I think, yes, of course. I think in best interest, that should not be a problem. Even, for example, I don't know, in my personal practice only, I'm okay even for self-referral, because we can't ask them to come back with a referral letter, to be honest. Sri Lanka is not yet ready for that. So yeah, we accept referrals from anybody. In my practice, I don't need even a consultant referral. Not a problem.
Okay. And about home visits. So there's a question on home visits. Home visits by a government or state healthcare team are not in practice so far. Of course, it's done by some general practitioners. So those visits would largely help the bedridden patients. Is there any suggestion to bring it into practice by the government side?
Yeah. So I think I covered it in the talk as well. So we don't have this thing established yet, and we are thinking of to be honest, we are looking into the model of like feasible models. How can this service be introduced? But I don't know whether we can establish home visits per se. Perhaps we can make this like convert certain underutilized hospitals, like as a suggestion for type C hospitals, perhaps district hospital, certain beds to nursing home type, where a physio visits could be one option. I think that's more feasible than arranging home visits, but it's under discussion, and we don't have a agreed path yet, but something to be quickly established, I think, within the next 6 to 12 months. So we are looking into that. Early stages though. But thanks for highlighting, Hassan. That was a I totally agree with you. It would really help them. These patients who are like nursing home level. It's a very cumbersome and not the best cause of action to ask them to bring to the hospital. So I think it has to be either they should convert certain things, units into a nursing home, or establish a mechanism for home visits. So yeah, to be done, hopefully within the next 6 to 12 months.
Thank you very much, Chamara. So I think those are the questions that we got in the Q&A here. So if there are no other questions from the audience, I think we can wind up today's session.
All right.
Yes. So thank you very much again, Dr. Chamara Jayatunga, for accepting our invitation and delivering this very insightful lecture on rehabilitation of a critically ill patient, which was a case-based discussion. I think our audience was benefited a lot after this lecture, and also thank you for answering the questions from the audience as well. So, on behalf of the Sri Lanka College of Internal Medicine, I thank our speaker, Dr. Chamara Jayatunga, and also all the participants who have joined us today. And so this brings to the end of the webinar, the Next Gen Forum today. Thank you very much all, and I wish you all a very good night.